Good evening, everyone. My name is Ashanti Carter, and I serve as the program manager of the Rodham Institute. I would just like to take the opportunity to welcome you to this very special installation of the Rodham Impact Speaker Series, where we will be celebrating National Public Health Week. The theme this year is Public Health is Where You Are. Tonight's theme is Public Health is, well, racism is a public health crisis. Yes, indeed it is. I'd like to thank our wonderful partners, blackdoctor.org. Hey, you guys watching from BDO. And I would also like to thank the George Washington Public Health Student Association, as well as the Black Public Health Student Network, along with, of course, the Rodham Institute. You know how we do it. So I'm going to go ahead and pass it to the president of the Black Public Health Student Network, Ms. Mara Stewart.
Thank you so much, Ashanti. Hello, everyone. Again, my name is Mara Stewart. I am the president of the Black Public Health Student Network, BPHSN for short, here at George Washington University. As president of this organization, we are excited for this opportunity to be involved in this discussion. Our organization exists to support and guide public health students of the Black diaspora and allies at the George Washington Milken Institute School of Public Health. In academia, professional services, and social endeavors to foster a highly involved community and to advocate for sound public health for the Black population at large. It is important for us to address racism as a public health crisis, especially at a predominantly white institution, and continue to have these open and honest conversations to figure out our next actions to dismantle racism from a micro and macro level. I would also like to include the remarks for PHSA. Sadly, Connor Hunshell could not join us tonight and has asked me to share his remarks. Hi, everyone. Thank you for joining us for this important event during National Public Health Week. Connor is the president of the Public Health Student Association. He appreciates this opportunity for public health students like me to learn about the impacts of racism on public health. We are all aware that public health is impacted by the systems we live in, such as housing, healthcare, and criminal justice. As racism and white supremacy are built into our systems, being aware of them and their impact is a crucial step towards improving public health. As public health leaders of tomorrow, this is an important lesson for our students to learn. Thank you again for being here.
Thank you so much, Mara. Thank you, thank you, thank you, thank you. So, in the words of our esteemed leader of the Rodham Institute, Dr. Gigi would say, I can't introduce you because you can introduce yourself and do a better job than I can. So as we kick off the conversation, I'm going to pass the first question to Mr. Toyese Oyeyemi. And you, sir, are going to talk to us about what is the Beyond Flexner Alliance and how does your work, right? How do you create a space for anti-racism in education? And don't forget to talk about your wonderful conference. You guys are gonna love this. He's fresh off the plane. You're gonna love this. Go ahead, Mr. Toyese.
Hey, thanks, Dr. Carter. Fresh off the plane, if you couldn't tell from the technical difficulties that I've been having so far this evening. I hope everybody can hear me okay. Excellent, excellent. It's excellent to be here. Thank you again for the invitation. My name is Toyese Oyeyemi. I'm the executive director of the Beyond Flexner Alliance, an organization that is based within the Mullen Institute here at the Milken Institute School of Public Health. And I've been the executive director of this organization for the last 2 years, but I've been involved with this organization for quite some time prior to that. Public health practitioner by training, and I'm also on faculty at in the Department of Family and Community Medicine at the University of New Mexico. As far as Beyond Flexner Alliance work in particular goes, what the Alliance is it's a national movement of interprofessional health justice leaders, scholars, ambassadors, and organizations with a growing network of over 40 allied organizations that have expressed some commitment and progress towards equity, really via our health professions, schools, and the institutions that train our health workforce. And the reason why we've really honed in on this specific space is because the United States, we graduate about 1 million new trainees each year in the health professions. Health professions programs, so those programs that exist within health professions schools, what we call academic health centers, your nursing schools, medical schools, public health schools, dental, pharmacy, et cetera. The amount of people that they touch, not just in terms of students, but also in many cases, they are the largest employers in their region. They tend to be, they produce practitioners who care for some of our highest needs patients in the form of teaching hospitals. They are tasked with having responsible engagement with communities. They are educators. They provide clinical services. They conduct research. These are these major lynch points, right, for change, and that touch a whole lot of people. So the organization essentially works to develop institutions that are socially responsible, what we call social mission. And the social mission of a health professions education and health professions program is essentially that schools are responsibly engaging in practices and policies that contribute towards equity, right, in the performance of their graduates and in the practices that they conduct. That's the work in a nutshell. Dr. I don't know if you don't want me to go into a little bit more in depth about the organization now, or if we're going to come back to that, but I'm happy to do either one.
We're going to come back to it. Thank you. Thank you. Now for you, Dr. Gigi, talk to us about the Rodham Institute and how is it that Rodham creates an anti-racist space in health?
Sure. So just briefly to introduce, thank you, Dr. Carter, and it's nice being on the other side of the panel because I can just kind of exhale and just talk. I'm a professor of medicine and actually have a joint appointment in the School of Public Health and have been at GW for 37 years. I teach, I see patients, but about 10 years ago, I really felt that there was nothing from the standpoint of an academic medical center. Of course, we have our incredible School of Public Health, but as a medical center in DC, there was really nothing that was, nobody that was working on health equity. There were lots of people working on it, but in terms of an institution with recognized by the community at large to address some of the worst disparities in the country, that we know of. And I'm not going to go through all of those statistics. I will suggest that you go to the uneven opportunity study that was commissioned by VCU and the Kaiser Family Foundation. Lots of great statistics. I want to just pay homage to Dr. Fitzhugh Mullen, the late really god of the idea of social mission and social accountability of medical schools. As you may know, Fitz, as we used to affectionately call him, and unfortunately he's passed away, was a pediatrician and somebody whose whole career was always dedicated to serving the under-resourced and the poor and the people that don't necessarily have a voice. And the work that he did in terms of the School of Public Health was to really create metrics that could really look at medical schools and say, okay, you're great, you're top 10 in terms of these different measuring sticks, but what about what you do for the community? And as you might imagine, the Harvards, the Yales and so forth, they were probably towards the bottom of the big list. And I think Meharry was number one, as far as I recall, the first time that this list came out. I also want to acknowledge Dr. Lynn Goldman, another pediatrician who heads the School of Public Health. And you don't have to be a doctor to be in public health, by no means. But I do want to say how we sort of address and try to break and dismantle racism is by listening and finding out what the priorities are of the community. We do not hold ourselves as the experts. You know, I always joke, and forgive me for saying this or repeating this for those of you who have heard me say this. We have people on this call from all parts of Africa, right? And so, you know, I'm of Egyptian heritage, so pyramids are very big, but there's no place for pyramids when it comes to healthcare. We should really be working in a circle where the individual, the family, the community is in the center, and the rest of us are spokes on a wheel. So spokes on a wheel implies that we each have value and that we are each equal. So, you know, dismantling racism sometimes feels like a huge slogan, but you know, as they say, the devil is in the details. So what does that look like? It means treating the people that we work with every day, that we see every day in our institution, as equal. It means making sure that there is pay equity, perk equity, but it's not something abstract, because especially those of us who come more directly from the African continent, we hear all the time about, oh, Africa has these problems and so forth, but there is never that sort of putting up the mirror to ourselves and saying, well, what's going on here? What's going on? And so I would say a step further, what's going on at GW? What can we do? Because yes, we need to do outward work, but if we're really going to dismantle racism and the structure, we have to start with ourselves. So that's what I would say.
Wow, that's amazing. Thank you so much, Dr. Gigi. That was wonderful. I'm going to pass it to you, Ms. Mara.
Thank you so much. And thank you so much, Dr. Gigi. We really appreciate you having this like really beautiful point of view after all your years of working at GW. I think it's so important. Let me see if I'm pronouncing your name correctly. Mr. Oyeyemi? Did I say it right?
Pretty close. Not 9 out of 10. 9 out of 10. I'll give you that. Yeah. Oyeyemi. Yes.
Oyeyemi. Could you please explain a little about the Flexner report?
Yeah, absolutely. So first of all, before I kind of talk about the Flexner report, I think that it was a really appropriate segue that Dr. Gigi just mentioned in recognizing the late Fitzmullen and his work in really canonizing social mission metrics, and the what I would consider to be the landmark paper that she's referencing back in 2010, 2011, which essentially, you know, as Dr. Gigi mentioned, was a reframing of the way that we've historically looked at and ranked medical school specifically. I will say that since then, our work has actually evolved into being about interprofessional healthcare education and not simply medical education, but I'll come back to that later on. But that point is really important because interestingly enough, the late Dr. Mullen and some of my current colleagues who had worked with him on that report 10 years ago here at GW, that really did mark the 100-year anniversary of the Flexner report. So it felt really appropriate that had taken place at the time. The Flexner report was commissioned by the American Medical Association and the Carnegie Foundation back in 1908. I think it was commissioned in 1908, but it was actually conducted through a series of site visits in 1910 and 1911. And when Flexner, Abraham Flexner, who was an educator by training, essentially went to every medical school in the United States and Canada. And the whole purpose of the report was essentially to chart what the current state of medical education was. What does this look like? The result of this 20-month pilgrimage that Abraham Flexner had done basically came out to this. Majority of the universities that produce our medical workforce are substandard scientifically. It ended up shutting down hundreds of medical schools across the country and Canada through recommendations, which they say were recommendations, but because of the structures that existed at the time, they were essentially pulling the plug on it for these purposes. One of the most important repercussions of the Flexner report, well, let me actually start with the positive, because I think that there's a reason why we actually do recognize Flexner's name and his contribution in medicine. One of the greater upsides was that the Flexner report did create this a standard, a scientific standard of what medical education should be. It was kind of the birth of the modern academic medical center, where it's now, it's a combination of a medical school with a teaching hospital, with, a department of science, right? It actually did have a long-lasting effect on the scientific rigor that was placed in medical education. And for that, we've seen several advances as a result of that. But I think that what we often do not talk about, and I think this is the most relevant part of the conversation for this conversation, is that the downsides, the negative effects of the report were that the recommendations essentially said, in addition to several of these schools being scientifically not up to snuff, many of these schools really that were located in rural areas, that were producing our workforce of color. And keep in mind, this is 1910, 1911. So you have to keep in mind what the tapestry of the country structurally, socially, politically looked like. He said that these shouldn't exist. And he essentially, with this report, legislated Black people out of medicine by saying that all but 2 medical schools at the time were completely substandard. In addition to that, there is an entire chapter dedicated right in the middle of the Flexner report to Flexner essentially relegating Black physicians into sanitarian positions, and so that Black people are not fit to practice, certainly not on white patients, and probably not fit to even practice on their own. But they would make handy sanitarians and should be seen as such. This is 110 years ago. This is only 100 years before the report that Dr. Mullen and our colleagues put together. This is, in a lifetime and a half that this happened. So the legacy of that report still remained. It closed down several of the medical schools across the country, and had a damning effect on where people were being trained. But it wasn't simply the role that it played on race. It also had an impact on the distribution of providers. Many of the schools that were shut down were placed in hyper-urbanized zones or in very rural frontier spaces. And we're still living the effects of that maldistribution and of that lack of diversity that was curbed. There's now a situation where we're constantly chasing parity in a system that, quite frankly, wasn't designed to do so.
Absolutely, absolutely. And thank you for that. Thank you so much. And we do see that even today, as you just stated, and we see how policy has impact health outcomes, negative health outcomes. So that leads us into our next question, and this is for you both. Can you talk to us about how your organizations and how you work with policymakers and stakeholders to try to fight racism and its impact in education and health? I'll turn it to you, Dr. Gigi.
I think the main role that we at the Rodham Institute play is that of convener, catalyzer, and collaborator. We don't hold ourselves up to impacting policy, but we certainly work with people from public health, but also with, we have 160 partners. So for example, the DC Healthy Housing Collaborative, which brings together the leaders in community who are from the neighborhoods that have, I don't know if people know, we have in Southwest DC, one of the most polluted areas on the Eastern Seaboard. And of course, that is a Black neighborhood, gentrified now. But they bring pediatricians, they bring lawyers. So that's one thing where we really, sort of try to amplify these, not to people who are already in these spaces, but rather to the clinicians, especially physicians. I mean, look, nurses are much more advanced, public health people, much more advanced, pediatricians within physicians, much more advanced. But let's face it, physicians tend to represent much more of the establishment. Of course, there's differences there, as well, which I won't get into. But so what we do is we try to shine the light on those issues that can impact especially patient care and education. I'll give one other small example. Every year before COVID, it was 6 years we were doing it, we would have something called See the City That You Serve, where every single intern that was starting at GW, doesn't matter whether they're surgery or medicine or whatever, there are about 100 of them. We would take them from Foggy Bottom and we'd bring our facilitators from both the community as well as academics, and we would take them through all the way to United Medical Center. So since many of them are not from DC, they would see the sites and so forth. And then for themselves, they would see what Anacostia looked like. And at United Medical Center, they would meet community leaders or clinicians that actually practice in the area to hear firsthand from them. And then of course we take the way back and then kind of debrief. But I think that what we do is sort of on the ground, I would say, really, making sure that we have our finger on the pulse and on the community, and that we don't speak for the community. I think clear. I mean, the analogy that I always use for Rodham, which I think should be for academic institutions, are it's a community that's a driver on the bus. We serve at their pleasure. We come on, we come off at appointed stops. If they don't want to go to that stop, that's fine. We are serving them with the humility that brings.
Wow, I love that. I love that. It's just involving the community because they're the best people. They're the experts on their own health and their own needs. So I like that. So, Mr. Toyese, talk to us. How does Beyond Flexner work with our policymakers?
So I think it's interesting because to the point that Dr. Gigi just made, I do love that analogy about the bus, and I think those are the tenets of community engagement, right? I think what has historically happened is that academic health centers and universities have seen themselves as this separate ivory tower that often is seen by community as parachuting in, particularly when it comes to research, right? Researchers at the institution have something they'd like to do, and they step into these communities, and quite frankly, it's a very extractive relationship. It's a very predatory relationship, and I don't think that that's a very provocative thing to say. I think that's been the model of what it's been. And there have been efforts, I think, by a lot of different institutions to be a lot more thoughtful about community engagement and have that be reflected in as part of their policies for this is the way that we are going to conduct community engagement out of this place. Particularly the fact that we tend to see universities as not being of community, but quite frankly, we as an institution play a central part in the tapestry of community. We are, those of us who are part of the institution, who make up the institution, are part of the community in a lot of different ways. So I think that that's a really profound takeaway as far as what our rules of engagement, so to speak, really are around community and what they're supposed to be, because that is not necessarily always the case. To that point, I will say that when it comes to Beyond Flexner Alliance in particular, we have 4 really core functions, I would say, right, around this. One is the idea of the social mission, where it's data and research. There's a social mission. Is there a proof of concept? Does this actually translate into health equity? I think the second part of that is, okay, great, we're on your side. We want to become a social mission institution. How do you actually support institutions on a practical pathway to change, right? Because I think we're seeing a change in society where you are seeing community pressure and pressure from students and expectations of those students to say, what is your social accountability to community and to addressing inequities look like? And I would say that folks need to continue to hold that fire to institutions to actually reflect that in their policies. The third piece of the work that we do is really around social movement and mobilizing, like community mobilizing around this. And to the point that Dr. Carter said at the top of the hour around our conference that I'm still foggy-eyed over in returning from, being able to find ways to actually generate a lot of areas of fire and galvanize people who can say, like, hey, we have this intersectoral group of folks. How do we bring together researchers, practitioners, administrators, community members, and students to actually create some fire and some change? And then the fourth piece, which I think is policy, right? And I think that there's the big P policy and then there's the little P policy. Now, as far as the Big P policy goes, I would actually say that the role of Beyond Flexner Alliance is really, we support policy in the form of statements and responses that are in line with a fairer, more just, better society, healthier system, and system of education. But I think as far as the little p goes, I think it actually is reflected in the way that we choose to develop metrics for change. So one example is the US News and World Report, right? You have the US News and World Report and a series of other modalities that have, again, to Dr. Gigi's point earlier, talking about the Flexner Report and Meharry and how we end up ranking these schools, this modality has really been around, okay, well, we're going to be ranking schools based off of reputation, based off of research dollars, based off of which schools are, producing sub specialists. Excellent. Okay, those things, how do those contribute to the social good? How do those things contribute to dismantling a legacy of racism that still exists? Those things don't do that. So what if we were to actually flip this up instead and have these type of modalities have their policies and their rankings actually reflect the fact that we need more primary care practitioners and pediatricians and psychiatrists, internal med, family med docs, as we mentioned, the fact that we need practitioners in areas that are highly under-resourced, frontier spaces, tribal spaces, hyper-urban zones that aren't adequately part of our health infrastructure. And how do we actually address the fact that, again, as Flexner Report's legacy still exists to this day, has systematically excluded people of color from an equal opportunity and access that we're still feeling generationally today. The fact that we still haven't closed the gap on Black men in medicine over the course of 50 years and actually gone the opposite direction is just one example of that, right? How do we actually impact policy to reflect that? And I think that, modalities like those reports, accreditation standards and expectations, and then actual institutional policies around admissions, curriculum, governance, all of these things play a role in being able to actually change what the tapestry of this institution looks like and the roles of it. So I think those are ways in which we influence policy. And I think again, there's only so much that an organization can do, but I think that the greater movement around it, right, like leveraging the broader network, all these changes that I'm talking about, they're not happening in a vacuum due to the manpower of a small organization sitting on K Street. It's happening because we have several people in a broader network, including some of the folks on this call, who work in the space of trying to push for institutional accountability towards equity.
If I could make a provocative statement, because that's all true, I completely agree with it, but the provocative statement is, when 10% of the world's population owns 90% of the wealth, we will be keeping on having these same conversations. I mean, and again, please understand, I agree with you, and this work needs to be done. The Black men in medicine, when I was in medical school at Michigan, I want to say that out of a class of 150, we were 30 of color. Most of them were men. And I started medical school in 1981. The numbers have gone down. Why is that? It's the prison industrial system. It is that 1 in 4 Black men are in prison. If you look at Washington, D.C., only 42% of kids in Ward 8 actually graduate from high school. When I was program director trying to recruit Black men as well as women, but Black men, that was my real focus, it's a small pool and everybody's fighting over the same people. So what I would say, and I would say that COVID really, for us at the Rodham Institute, accelerated our commitment, or maybe perhaps hyper-focused it, because people were just suffering, right? So getting those masks out to people, 560,000 masks that we distributed, webinars such as this, but also just, illuminating, shining the light on what people are saying and experiencing. So if I would look, if I had a magic wand and could really make a difference in equity, I would start with economic development, just like they do back in Africa, right? And the different, AID and all these things. I would do that. I would focus on education and, of course, the jobs. I will tell you that in Washington, D.C., the leaders are incredible, and they are doing a lot of work to get co-ops and teach people aquaponics and hydroponics and doing their own, building senior housing developments. One of the churches, Temple of Praise, does. But I think I would like to see the conversation step back, because frankly, it's implied in everything that you're saying that you agree with me, right? Because of the framework. But I would like to make that more explicit, because we can only work within those boundaries that are very limited. And yes, we can do work and push things, but it will always be limited as long as the economic power structure and the hierarchy remains. And finally, I'll just say one more thing. I was just on a call this morning, so this is kind of fresh up. Yes, there are people with wonderful intentions in academics. These were not people from the School of Public Health, by the way, that have very good intentions. But what you'll see is like, yeah, we need to engage the community. Well, why aren't there community members right here at this meeting? It's always an afterthought. We'll come up with the structure and then we will bring them in. It's not how it works. I mean, that's the very definition of community, based participatory research that, of course, public health has pioneered and pushed for. So I guess what I'm saying is we need the public health leadership, because you are the most qualified to keep us accountable. That training is something that I think that there needs to be a much stronger partnership where you're actually, like Beyond Flexner, are in the leadership position.
That's true. That's very true. Thank you so much for your comment. And you said something that pricked my ears. You said 10% of folks, they own 90%. So
Something like that.
Let me take the people back. So when I talk about structural racism to my students, I liken it to a Lego block, right? So my little brother, he loved Legos when he was a little kid. He would build houses, towns out of his little Legos, right? So that little Lego block, that's structural racism. What we build from those blocks, houses, schools, churches, those are the institutions that have structural racism that's weaved into those communities, those institutions, right? So it's the normalization of whiteness. It's normal. It's normal for BIPOC folks to struggle. It's normal for Mr. Johnson, who lives east of the river, to just eat unhealthy food, and that's normal. So we have to flip the script. Oh, excuse me. We have to change the narrative. Let me, make sure. We have to change the narrative so that we understand, right? That the problem, it's bigger than us. And if we can get the message out there and start dismantling those little Lego blocks, then I think we can be on the right path to achieving equity, not just health equity, education equity, housing equity, economic equity, right? So just a little reminder for the people that structural racism, it's a little block, it's weaved in everything that we do, even our language. Good neighborhood versus bad neighborhood. I'm guilty of saying it. Good neighborhood versus bad neighborhood, right? So we have to change and flip the script on how we say things. So I'm going to get off my soapbox and pass it on to Ms. Mara Stewart.
Thank you so much. Thank y'all. I really am enjoying y'all's perspective. It's really it helps a lot as a student. I think my question is for both of y'all, actually all three of y'all, if y'all want to all answer, is I know for me personally, I have been at all predominantly PWIs since I was in elementary school. So this has been most of my life in education. And so I've been having these types of conversations from a very young age. And at this point, almost in 6 weeks being graduating, it's hard to see, okay, so I've learned how to have these conversations within academia. But when we move outside of academia, when we are finally put to taking theory into practice, what would y'all like? Do y'all have any advice for students who we are pursuing to continue having these conversations? But a big fear has been, how do we not get so tired? The burnout has been also real. After taking 2 years of being on this committee in this organization, it's tiring to have the same conversation over and over and over with people who say they have good intentions, but their impact has been negative. And
Take it away, Dr. Gigi.
Yeah.
So, when I feel bad about the future and then I meet somebody like you, I know we're going to be okay. Because you, as a leader now, but as a future public health leader on a bigger scale, are asking the important questions. And more than that, integrity and your heart, because this is all heartfelt work. This is not about building, we can also build our careers. These are not mutually exclusive, but this is sort of a commitment. It's a civil rights issue. This is the same kind of fire that helped people in the civil rights movement, that keeps people going. I feel that strongly about these issues. One thing that helps me with my burnout, because being a physician these days with all the pressures and the insurance companies and everything, is actually interacting with the community. Because, it just reminds me of what's important. So to your original question, how do you take sort of theory into practice? I'm going to give you my own example when I was probably close to your age. Maybe a couple of years older. When I was in medical school is when the AIDS epidemic began. And I was at Michigan, came here to Washington, DC. This was in the 80s, mid 85. And I did not know anything really about LGBTQ people. I didn't. My dad had a lesbian postdoc and, that kind of thing, but it was not any kind of substantive interactions. And, it was a 1 year, 100% mortality. So I did not have the luxury of, kind of sitting back and observing and all that. I would just ask people, I'm like, I don't know about your community. What do I need to know? What do I need to know about you? I would start off, what is important to you? Tell me about you. What are the issues that are going on in the community? I learned so much, so that when you bring that love first, humility, compassion, and a real interest in first of all, seeing people as your equal. I'm not going to save anybody. I can barely save myself. But, seeing people as equal and asking the questions and just listening is my best advice to you.
Thank you.
Toyese?
Yeah, I'm happy just to add a couple of really quick remarks. I think that is a really strong question. And I was reflecting on it even as Dr. Gigi was talking, because I think that at the cross section of both finding that soul and spirit of of social improvement and social impact, while also figuring out how best to curb burnout and adequately take care of self at the same time. It feels like we're on this collective quest for that right now, right? Like more than ever, it feels as though that is a really shared experience. And I imagine that has been before even the last couple of years, but something about the current time that we're in makes it feel as though it really is this collective experience that we're all figuring out at the same time, which is really unique and interesting. Which actually leads me to the two things that I think would be effective ways to address both of those. One is in narrative collection, right? I think looking for opportunities to be able to actually share your stories and hear the stories of others. this right here actually counts as that, right? Like I think that this is one example of doing so. Being able to be in spaces where you can hear the perception of others and be able to also share your own perspective is underrated. And right now we have more access to it than I would venture to say we've ever had in human history, because of the fact that we've now, over the last couple of years in particular, built an infrastructure that really allows for this type of connection that we didn't really have before, at least not in mass. So I guess along with that goes into, you know, being able to find the right avenues to be able to sort of, you know, tell your stories, learn stories, hear stories, and go back to that human connection point that is at the center of all of the work that we do, first and foremost. And then the second is really restorative spaces, right? And I think that that's that could probably look as that could probably be defined differently by different people. I would say that maybe the common thread between any type of restorative space is the obvious one, which is that, you know, you find it as a place of refuge. And I think that the place of refuge does require trust and vulnerability, or at least one or the other, quite frankly, right? Sometimes you build trust through vulnerability, and sometimes, you know, you become vulnerable because you put yourself in a space where you already trust, right? So fully recognizing that it's not as nuanced as that. So I don't mean to be reductionist in saying that. But I would say that being able to find places where you can restore, and I guess maybe going back to the initial question that Dr. Carter had asked around the work that, you know, that we do, my organization does around that. You know, we just, a part of our conference just last week in Arizona was bringing together folks of our broader student assembly into a space before the conference even began. No administrators, no staff, no faculty. It was simply students. And from what I understand, they who had been planning this for months. This is, you know, and able to kind of address both of those, right? Both have this, you know, like restorative space where they're also able to both collect and exchange narratives, and really discuss the fact that, you know, we have all of these different experiences, being in healthcare, being in medicine, being in public health, being in academia, and, you know, largely being people of color who, you know, have experiences that really do need to be spotlighted and validated, and discussed and told and shared, right? I think that one of the things that becomes a little bit of a impediment to that, and this is, I always say that I think, you know, as part of the institution and as part of the community simultaneously, we have both the right and the responsibility to be critical of our institutions. And I think that in saying that, one area of obvious criticism of not just not our institution, but the institution of academia and academic medicine, is that the reason why we have all of these individual independent heroes and champions who are out here doing this incredible work, quite frankly, is because they're doing it out of necessity, because their institution has somehow marginalized them to where they have now, you know, there is the need for these kind of narrative collection, this need for restorative spaces because of the institution, right? In response to that. So one of the bigger questions at a macro level needs to be, you know, how the hell do we, you know, pull institutions to not be harmful towards, you know, towards individuals who need this type of restorative space, right? Like what if we were to actually to rethink this whole institution of education and academia, to where, hey, rather than, you know, the need for these individual disruptors, but we actually instead have a system of education and academia that completely negates the need for individual disruptors, because we instead have a system that's worth protecting and preserving rather than disrupting.
If I could also add, I mean, that is spot on. And I feel like you were listening into some of my conversations earlier today. But I again feel that this is also related to the economics. I mean, you know, I'm a general internist. My colleague who is a surgeon, or even a orthopedic surgeon, because they're at the top of the heap in terms of reimbursement, it's about how you're getting paid. If we now have a contract, for example, where there is no credit for academics. It's just how many patients you see, and that's it. So if that's the case, the further down on the hierarchy that you go as a generalist, what does that do? It really, it reduces the value. It's of course actually causing more and more of a problem in terms of getting generalists out there. But again, it is, I go back to the paradigm of equitable distribution, sort of in everything that we do, including at the academic educational level, and who's making these decisions and how is the district, just let's take something very, very simple. And I know this may be going a little bit off the tangent, but adjunct professors. Adjunct professors are mostly women. They do a lot of work, a lot of teaching, and guess what? Get no benefits. Let's just call it out, right? So that is one example where the economy, the political economy drives outcomes. So I don't think that these are either or, and just let me clarify that everything has been said, especially about policy and theory and all, that is so important. But I would say adding, that accountability, as you're doing, obviously at Beyond Flexner, and frankly, looking at the hypocrisy, because what we're seeing right now, especially in academic medicine, is all of a sudden, from having nothing, all of a sudden DEI, white coats for Black lives, you hear great speeches, but then when you're actually talking about supporting certain initiatives, crickets. Am I right?
Mm-hmm. Mm-hmm.
So basically you're saying that people need to put their money where their mouth is.
Thank you.
And then we also, as students, staff members, people in the community, we need to hold institutions accountable. In my program at the Graduate School of Education and Human Development, we call these developing town gown relationships, right? So an institution, an education institution, is not supposed to just set up shop and, I'm just gonna use a couple of terms. I do apologize if you find them offensive, but we're not supposed to go into the community and be a poverty pimp or a culture vulture. That's not what we're supposed to do, is to develop these relationships. And with DEI, diversity, equity, and inclusion, it's not just about putting a Black face on something, right?
Mm-hmm.
Or a brown face. It's a diversity of thought, right? People who are able-bodied, right? There's so much that actually goes into diversity. So I think you're absolutely right, Dr. Gigi. Thank you for that. Thank you. Ms. Mara?
I have another quick question for y'all. So when looking at power, of who has the power in these kind of conversations, it's often quite difficult as a student to kind of call out when something has happened, when intention has turned, when a positive intention has led to a negative impact. So when we're discussing these institutions, and when we know, like, I'm not going to be a student forever, but it will take me a while to climb the chain of commandment. And as we wait, it's very hard to figure out, when do we have these conversations? When is it time to it's time to push for these conversations to be had? But the fear of, losing a job, fear of possibly having someone retaliate against you often holds a lot of, I know, students, POCs, BIPOC, you name it, back from having these types of discussions. So how do you see us still having these kind of discussions when we know we live in the power dynamic is very difficult often in these situations and scenarios?
I have a lot to say, but I'm always talking, so I'm going to yield to my colleague to sort of have first dibs.
To the point that you just made, Mara, it's not even just a fear of retaliation, right? Like, I think that's obviously a big one. There's other concerns too, right? Especially for some of the adjunct faculty that Dr. Gigi was talking about, right? And for other staff as well, where it's not just, okay, all right, possible retaliation, possible loss of job, but also the minority tax. And now it's like, all right, you're the one who brought this up, so now you lead this effort, right?
Exactly.
You're the one who brought up the concern. So this is now your responsibility. And that's even more absurd when you think about the fact that students are the ones who are being placed in that position too, right? It's like, all right, so yes, we acknowledge that this is a problem. You should do something about it. What? Then what happens is you have these really fringy responses where it's okay, we'll put this person, dom them as the DEI head of this, but without any level of support or authority or accountability from the folks who are actually making a lot of decisions, which is again doing more harm to people in junior faculty positions, staff position, and students. I guess I have more of just reflection on it more so than really a response, but I do just want to acknowledge the fact that so I guess so Dr. Gigi, I think if you have plenty to say, this is definitely excellent timing. But I do acknowledge the fact that that is an absolutely real problem, and I think that what happens more so than not, in my experience, that tends to get invalidated as being it's not really what really goes on. I can say. But it absolutely does. It absolutely does. It's a major concern for change. What is the response? Is it to just wait until folks retire and hope that a new generation can? No, that's not a reasonable response. I would say. In fact, I think I would challenge us, including everybody who is listening to this right now, to really be thoughtful about ways in which. What does a multi-level approach to that look like? Does that mean many of us have mentors who are in those spaces? We can engage those mentors in some of these conversations, right? At a certain point, the conversations get old and it's like, okay, what's the actual action? But when people, the reality of it is always going to be the fact that systems and institutions are made up of people. And until those people, overwhelmingly shift to a critical mass that reflects the change that we actually need to see, these things are going to continue to be a combination of lip service and a lot of impatient conversations.
So let me add to that. You don't have to be a student to have retribution. I will tell you that as a senior faculty member of color, woman of a certain age, because one is questioning the very sort of the hierarchy, the power dynamic, the very paradigm that I face real challenges. And I've been, people have tried and failed, obviously, to silence me. I think what's been most difficult for me, and you have to be mindful about this and alert to this, is just because somebody's of color does not mean that they're your ally, and vice versa. Because as people get promoted to these different, the tokens, right, in these different positions, because there is not anything that's really looking at questioning the system, they become co-opted by the system, no matter what their initial intentions are, because they are a disruptor. If you are talking and having these different, you are a disruptor, right? So I would say the following. Don't let anybody ever take away your power. Students have a lot more power than you realize. Perhaps not individually, but together. One of the things that schools are fearful of is that students complain. And I don't think that you guys really get that because, the power dynamic is such and it's so uneven on an individual level, but collectively, there is a lot of strength. I would say that that really having allies becomes important. And then as you go up the hierarchy yourself is, everybody has different personal situations. I'm single, I don't have children. I can speak out. I have the liberty of speaking out. My colleague who maybe has young kids or, has a big family to support doesn't have that luxury. So I'm not in a place of judgment. People do whatever they feel comfortable with at whatever time. When I was your age, I think I still did speak out, but not in the same way that I'm speaking out now, because I did have grades to consider, because I did have to think about where was I going to do the residency. But I think the first thing, because it can kind of be crazy making, like when you want to say stuff and you know that you want to say it and you're kind of biting your lip, but don't let anybody ever take away your power. You keep saying those stories. You have to think about and strategize how to do that, in what format to do that. Is it a group or whatever? But don't let anybody silence you. You have, and you particularly have a lot to say and are very smart and are going to do great things. So don't let anybody stop you.
Thank you. Thank you. We actually have a question here, and this will be our last question because we're almost out of time, but I really want you to answer this question. So Dr. Gigi, how do you address the atrocities that go on at the VA hospital among Black veterans? Why does it take so long for serious illnesses to be addressed?
The same reason that, again, this is going to be controversial, but this is how I feel. There's this awful war in the Ukraine, right? But there have been wars, in Rwanda, in Syria, in Yemen. Why is it that we get to see the humanity in the faces of those people? And the food, instead of being dropped off from a helicopter where people have to scurry and collect the individual rice, there, versus having it handed. If you haven't seen the Trevor Noah bit about the racist coverage of Ukraine, I would really suggest that you do. So I'm going to give a quick quote from the wonderful webinar that we had about the wrecked slave ship. There was a wrecked slave ship off of the Cape of South Africa. And the captain said, everybody survived. They were taking slaves from East Africa. 1.2 million slaves actually came from East Africa. Well, that's true. All the white crew and everybody survived. The 108 Black slaves died. So if you start from that as a premise that people are not people and don't count, is it any wonder then that Black veterans, Black fill in the blanks, don't count? So again, this has to do with really looking at the system and the power dynamic. You made such an important point. I mean, let's be real. What is the country, the foundation of this country? People like to talk about, patriotism, America, but it's slavery. It's so racism, violence, and greed. Let's be real. That's what's baked into the fabric. And until we have those hard discussions, then it's going to be, like Obama, but we didn't do it. That's, trimming the top of the tree, but we've not done anything for the roots that run very, very deep.
Wow. And I think that is a great statement to close on. So racism, if we do not address it, we will continue to be in crisis mode. So what I've gleaned from our speakers, we have to galvanize the community, we have to galvanize our students, and we have to hold the powers that be accountable. So on behalf of the Rodham Institute, I would like to thank Dr. Gigi El-Bayoumi, Mr. Toyese Oyeyemi, and Ms. Morris Stewart for joining us in this great conversation. Please join us tomorrow. It's my favorite. You guys, tomorrow we have Dr. David Carlisle, the president and CEO of Charles R. Drew University of Medicine and Science, my alma mater, yay! We have Dr. Candace Chin and Dr. Anuntri Vichare, and they're going to be talking about the future of our workforce. And you'll see Dr. Gigi on the other side as the moderator, and I'll be her co-moderator. Thank you so much again, everyone, and have a good night.
Excellent. Thank you for the invitation. Take care, everyone.
All right.